No, you notice
and I have 11 o'clock, so I think we can go ahead and get started if you guys are ready.
Sure, and on my bio slide, you don't have to read that whole thing. You can summarize, because it always takes up too much time.
Okay, sure.
Thanks.
Well, we want to welcome everyone today. The presentation for the Flex Quality Network Council meeting today was sent out this morning at 9 o'clock, along with some additional handouts that we'll be covering during the session. We're very pleased that everyone was able to join today, and hope everyone is staying safe. These have definitely been trying times, and if you have questions going forward, open up the chat and just shoot a chat question. Be glad to monitor that and make sure that your questions are addressed. You can also unmute your line by clicking the microphone button beside your name, and that will unmute. And if you have any difficulties, though, doing any of those tasks, you can reach out to Ali Orwig at IRHA or myself, and we'll do our best to assist you. We do have all the lines muted to cut down on some background noise. And I apologize, I'm a little bit hoarse today. Today we're going to cover part 2 of a emergency preparedness education, COVID-19 and future healthcare preparations. We're very honored to have presenting for us today Lesa Schlatman, Program Manager for Hometown Health. And Lesa has an extensive background in care coordination, population health, process quality improvements, and has presented for us in the past and just done a really great job of providing some really good information and great takeaways. Joining her today is Kerry Dunning. Many of you know Kerry, who assists us with our swing bed initiatives for MBQuip. And Kerry also works with Hometown Health on various education programs, and will be adding to today's session too. So at this time, I will turn it over to Lesa.
Thank you so much, Becky, and welcome everyone. I'm happy to be meeting with all of you again and providing some further information as we kind of work through this COVID circumstances that we're dealing with, and kind of, you know, as we move forward, we have to really start to think, how is life for us going to change, especially in our healthcare settings? And so that's kind of the focus today. We're going to talk about the stress that can occur, you know, not just with patients and families, but with the staff that are caring for them. We're going to throw in some infection control again, and really kind of look at what are some things in the ED we can do to help with those workflows. And so, as I just mentioned, it's really, you know, looking at identifying and addressing those emotional needs of all the patients, the family, and you guys, you know, the ones that are taking care of them. And, you know, how do we adjust our infection control as we move forward? So looking at you guys have been all over the place with your plan. The last time I presented, you guys were talking about the 4.5 stage. You had kind of went up and back and forth, and your mandates kept changing. So it's really fun to put that information together for you, but I think currently you're following the 4.5 stage reopen plan. You have not determined that I know of your stage 5 date. You're still requiring your face coverings. That's per the executive order. So I know we've had discussions about people not wanting to use face masks, but those are mandated now. Hospital visitations are encouraged, but with precautions. Now, obviously, they will adjust these if we have spikes again. Illinois, we were doing great, but now we're incurring some spikes. Adults with disabilities, day services can operate, but other congregate settings are going to remain closed for you guys. Continue your screening, testing, and tracing. Businesses are going to follow those capacity limits, required screening, social distancing. And nursing homes, assisted living, they are requiring that you provide indoor and outdoor visitation, but with those followed guidelines. And all of that, if you see the two at the bottom, I'm sure a lot of you have been there. If you go out to those website links that I've provided, it does talk about all those other details and a lot of resources. So you guys have really ramped this part up, because your numbers were definitely below this, but your state is over 200 testing sites now. I think you had like 150 last time. You are testing about 7,000 Hoosiers daily, so that's great. And you now have these strike teams, which I think is phenomenal. So these strike teams will go out when there's positive cases in kind of congregate areas or high-risk areas. They will send out these strike teams to kind of assist, do the tracing, help with resources and all that. You're still using your centralized reporting process for tracing. We have over 600 contracted tracers now, and you're doing about over 2,500 calls daily to positive cases by those contract tracers. And all positive cases get an email, text, and tracer call with follow-up so that they can help them with resources and getting treatment. Reminder, healthcare systems, you must assist in this testing process for all symptomatic Hoosiers. You know, that is an ISDH guideline that you must follow, notify positive cases, and complete that contact tracing. So what that means is you just have to partner with those contact tracers if you can to try to make sure those are getting filtered through that central reporting process. Okay, so let's jump right in it. When we're talking about stress and COVID, let's talk about stress, our staff first. There is a lot of physical strain that is happening for these frontline workers at all different levels, really. It's not just frontline, but you know, the physical strain of wearing that protective equipment, a lot of them complain about dehydration, heat, exhaustion that is happening because of the equipment that they're putting on in the long hours because of the increased workloads. Constant pressure to be knowledgeable has definitely put a physical strain, and maintaining infection control processes. I have an aunt who's an ICU nurse at the bedside, and we definitely have talked about the amount of stress that they go through trying to maintain those infection control processes because there's a lot of steps involved. You know, it's just a rigid and repetitive environment that, you know, takes a lot to go through a day. Now, there's also mental strain. You know, the isolation, because others fear contact with treatment staff. There's been a lot of staff that have really had to deal with this, and it's been a little shocking to them and disheartening to them because they care for patients that have COVID, and now others around them in the communities and stuff don't want to come in contact with them because it's kind of like a stigma. There's also the isolation the other way, restriction on touching others even after work hours, you know, other friends, family, your loved ones at home. Fear of infecting them, fear of impending separation from your family, that definitely puts a lot of mental strain on. Those workers that are at the front lines, boy, what am I doing today? Am I accidentally gonna do something wrong and not know it and take this home to my family? Worry of self-infection along with that. The mental strain of caring for co-workers and colleagues have been huge. You know, these are people, they were kind of almost like going to war. They've been in the trenches with them. They've been working long hours. And they've been trying to get through this together, and now suddenly they're ill and your coworker and you're caring for them. That definitely, the mental strain kind of goes to a different level there. You know, the empathetic mental strain that happens because sometimes staff, they're the last interaction that happens with this dying patient who was not allowed to see their family or have any loved ones at the bedside. And now this worker was their last interaction. And that's a heavy burden to hold on to, knowing that holding that hand if you can, and that their way out of this world, you are the last known contact. So, you know, and then the uncertainty of the unknown. That definitely, the strain for that will never go away because even now we think we know, but then we find out new things. And so the unknown is definitely a worrisome burden. Then we have conflicts that happen. We talked about this in the last presentation a little bit. We have a lot of ethical decisions that were being impacted by the care for these patients because, you know, as a nurse, we take ethical oaths. We know that we have to be ethical with the care that we give and the decisions that we make for all patients. A lot of those had to be stepped upon and kind of altered because of the different needs that were happening, the different shortages that were happening, the different surges. You know, patient family wishes versus the protocols that are happening. That's definitely apparent when we don't allow people at the bedside. I really hope moving forward with new pandemics, we have to find a better way to accommodate for that because that can happen to any of us. I mean, I don't want to infect my family, but for them, especially if you have children, not having them at the bedside, if you are, you know, your final days are near, that can be life-changing for those children. Varied quarantine health response, you know, the guidance it kept, we've heard a lot of stuff. We heard we got to do it this way, and then we found out, nope, we're going to do it this way instead, and then they come back and they'll change it again. You've got officials arguing about all of that. You know, those conflicts really put in a lot of added stress because, gosh, if they don't really know and they're telling us to do this, I don't really know, are we really doing the right things? Those constantly changing regulations. You know, interlacking needs of the systems, when you're lacking supplies, but you're trying to maintain a high standard of care, there's a huge conflict that's taking place there. And that's not every system. You know, all of this stuff that I'm covering may not have happened in your particular situation, but they definitely happened in these bigger settings. And we don't know what's around the corner or what's coming in the near future. So we have to talk about these things and make sure that we understand what's involved and what steps we can take to try to identify and address these so that we don't have to deal with them again. The conflict of health workers' self-stigma about voicing their needs and fears. We all saw this on the news a lot. You had a lot of healthcare workers that came forward complaining, and then you would hear about the fallout from that. Some of them were reprimanded or lost their jobs, or things that were posted on social media were taken down because, you know, big systems were trying to hide that. Your healthcare workers should never feel bad about voicing what's going on with them. We'll talk about some of these details a little bit more. That lack of equipment to give everyone the same care. They felt like they were choosing who lives based on ventilators and those kinds of things being available. You know, wanting to be safe. So there's a huge conflict for, you know, a healthcare worker. I want to be safe, but then I have this responsibility to care for these others. So that creates a conflict because maybe I want to stay home. I'm a healthcare worker. I'm scared. I don't want to infect me and my family, but I have a responsibility as a healthcare worker to go to work and help take care of those. So there, again, that creates inner turmoil. And then the guilt. What they've witnessed, the practice variations, the standards that were impeded upon, all of this stuff that we've just talked about comes with a heavy load of guilt that can be surrounding. So, you know, compounded on all of that, you can really see the amount of stress that we may not be openly thinking about. Your staff is definitely, you know, coming into contact with a lot of these issues. So let's look at the patients and families. So we're trying to care for them, but we also have to understand, you know, in our normal situations, I think we're a lot more empathetic with things, but because of the surges and the high volumes, some of that kind of fell to the wayside, and not on purpose, but we have to understand the stress that they're dealing with due to that lack of understanding of the medical processes already. And now you add in this pandemic, this virus on top of it, it creates a lot of confusion. You know, the terminology, there was already terminology. Now we're adding a lot more terminology in the new protocols that were enacted. The ones that maybe weren't in there before, but now they are. This creates a lot of stress. Exposure concerns when they leave their house. Patients want to come to their doctor. They want to go to the hospital. But I don't know. Their concern is, gosh, I have to go. I have CHF. I need to go to the ER. Boy, I'm really concerned, though, what's going to happen while I'm there. You know, they're already worried about that before they even go out the door. Exposure in the middle settings, that ground zero. Lack of trust in healthcare, because not on purpose, but our constant conflicts and changes that are very media spread. I mean, we're doing it openly, right? On social media, right on the news, right on television, live broadcasts. There are constant conflicts that are taking place. That works against us in the healthcare settings because now the patients, the families, the people that are listening to this definitely have a lack of trust in what we are doing. Patients that experience isolation and social withdrawal because either they've isolated themselves to be safe, or maybe they became a little sick and got a positive test and had to be isolated, and then just socially being withdrawn from their normal routines and stuff that they've done. And we've all, I mean, I've experienced that. The things I used to do, I no longer can do. And it can be very disheartening. You know, stigmas associated with the exposure. Patients that become positive, you know, everybody's wanting to know, but then they're treated like social pariah, you know, so everyone's running away from them like the bubonic plague. And I get the concern and the fears, but that's a heavy burden again for them to deal with. Dealing with post-infection, it's almost like when you get an amputation, you know, that self-image change that takes place. the impact of the trauma, basically, of having this infection, having had to cope with that positive infection and the perceptions that happen afterwards. Those self-perception changes, you know, they no longer feel normal. And again, this creates a lot of stress for them. So why are we worried about stress? I mean, because we know it's there, we know we have it, but what you have to under that stress response can be even higher to a crisis level when you have patients or staff members that have underlying medical conditions on top of it, disabilities or developmental delays, people with existing mental health conditions, substance abuse disorders, the homeless. And I know we've talked minimally about the homeless and all of this, but the homeless was definitely a key group that needed to be targeted for containment. People facing disparities, people living alone, isolated, or in rural areas, and obviously frontline workers and caregivers. Okay, so the next step is why, again, we understand that there's stress. It can definitely be exacerbated by those things, but what we have to understand is it can lead to bigger and worse things. So the potential side effect is that constant worry. We've gone to a new level. We were worried before. Now I'm at an anxiety level of worry. I'm constantly worrying about my health, finances, loss of job or services. It interrupts your sleep patterns. You start to make poor nutritional choices, or they just aren't eating at all. The worsening of those chronic health conditions and mental health conditions, a lot of them turn to increased tobacco use, or they turn to alcohol or substance abuse. So what we need to do with that is we have to have a process internally. As a healthcare setting, you have to have an internal plan to identify and address stress for staff. You need to have a screening process for your patients. We have some of these in place, but we need to think more thoughtfully about, are all the key steps there? Are we going to catch the important things that we need to? Screening for families as well, you know, action steps and resources. What are we going to do with it? What follow-up plans are we going to have in monitoring? So first, we have a lot of different things that are happening with your staff. So we have to understand staff behaviors. There's a lot going on behind the scenes that as administrative levels, department heads, maybe we aren't seeing this stuff. So we think everything's fine, everyone's coping, everyone's taking care of patients, well, we're doing good as a system. But you have to look for certain behaviors. People that aren't coping well or probably are getting to a crisis level of stress are typically working long stretches. They're keeping too busy. And that's a coping mechanism. We know that, you know, grief, when someone's lost a loved one, a lot of times they'll just dive right into work, keep themselves busy, and never kind of take that time they need for themselves. We have the silent sufferers. We know that. We've all worked with them. They typically never complain, and they'll just kind of do whatever mechanically day by day. And we have to know who those people are, because typically under the surface, there's a lot more going on. If you notice, people or coworkers, I mean, these could be neighbors too. These kind of apply to everyone. We're suddenly making big life changes. I'm going to move to New York, or I'm just going to sell my house and live in an RV. You know, sudden drastic life changes sometimes means they're trying to get away from those underlying stress. Negatively assessing their work contributions, or not wanting to talk about their work experiences with others. Again, these are lack of coping mechanisms. Worried they will be removed from duty if they complain. So they just feel like I have to suck it up, per se. You know, behaviors of guilt. You know, they make statements like it would be selfish to take time to rest. They may not say that out loud, but they're saying it to themselves. It would be very selfish of me to take time to rest because they feel obligated. Others are working around the clock, so should I. And they feel it's their duty. Needs of survivors are more important than the needs of helpers. And they feel like they have to be a team player. I can contribute the most by working all the time. And then that final line, this is, I guarantee you have a lot of workers that are saying this. I must stay strong for my team, especially those long-term staff, those seasoned staff members that are, you know, your charge nurses, the ones that are kind of those leaders in their units and areas. These are the ones that are probably under the most stress because they don't want to show that they're wavering, because they're setting an example for everyone else. You know, so rule number one, every staff member is experiencing stress, but just in different levels and forms. So all of the information we just reviewed explains this to you. You know, as employees, employers, or coworkers, we have an obligation to understand this and identify when when help is needed. So develop your plan for your staff. So if you develop policies surrounding workloads, and pandemics, develop policies requiring interventions and counseling, develop monitoring tools and weekly screening processes, key behavior identification, treatment options, set up your resources and have resource lists available. I didn't go through and make a slide with the million resources that you guys have. It is all available out on your Indiana website. The link that I've put on the bottom of most of these pages, you can go out there and collect those. And they do alter a little bit because in your surrounding area, you may have other resources that you want to include. And you need to have a policy for release back to work. I'll probably repeat myself and say this again, but the reason for policies sounds like a lot of paperwork, but the reason for policies is they remove obligation. And I know that I say this later, but I want to reiterate that. When you force your staff to follow protocols and policies, it takes the guilt and the obligation away from them. So they have to follow the policy or what's expected of them. You can do a lot to impact stress when you force them to follow a certain process internally. You need to develop kind of a different plan for your patients and families because, you know, we cannot force treatment upon them unless it's that legal requirement where they're a danger to themselves and that kind of thing. So, you know, this is a little different from internal staff. We are obligated to try to identify when help is needed, but we cannot force patients or families to follow our recommendations. Our goal is to identify when help is needed and to offer that help in different forms. So we want to screen, obviously our depression screening, we're really good at that, substance abuse, signs of that ineffective coping, kind of like that last screen I went over. Those same signs of ineffective coping are really important to kind of identify because there may be a lot of underlying stress involved there. Provide those treatments, medications, counseling, spiritual needs at the bedside. We have to pay attention. I think we were just in survival mode during all of this COVID and still maybe are in areas where there's surges happening. We have time once we finally get through this, that if we have to prepare for future pandemics and do a little bit better about having those resources at the bedside. These patients are scared and worried and, you know, the stress of already being infected, the families worried, you know, having the, you know, the pastors at the bedside or whatever it is we need to do and how we can do that safely, we have to figure that out. Provide that resource list out to the patients and the families so that maybe they won't agree to what you're recommending right now, but maybe they'll seek that assistance outside of it. So, you know, extensive community list, contacts, etc. Educate your patients and families to help reduce the stress of what's going on. You know, you heard a lot of patient stories where nobody was talking to them, nobody was talking to the family. Once in a while, you'd have a great nurse that would get on a phone and call out to the family and keep them updated, but it wasn't a common process that was in place. And I think, you know, and it may be in your area, and if it is, kudos to you, because it's very important for them. They just want to know what's going on, especially if they're restricted from the bedside, they're going blind. Their loved one could have passed and they don't find out for a whole day because there's no concrete process in place to keep them informed. Video, FaceTime, there's got to be a way that we can keep these families and patients connected. Keep that communication open. Accommodate for family needs. Maybe we talk about waivers in the future. I have an 11-year-old, and if he became sick with COVID and they told me I couldn't be at the bedside, I'm probably going to end up in jail. I'll let everyone know that now because I will adamantly try to scrape my way to that bedside because that's my child. Are there other isolation options that allow some kind of wall between them, but at least they're there and they can interact, they can see, they can hear? We have to do better. So patients and family post-COVID. So we're talking about when they're there, but also once the patients and families are no longer in our setting, we have to think about this. We have to have a process for monitoring. We are hearing so much about the long-term effects of COVID. So what does that mean for us? What do we need to do? How are we going to monitor that and keep track of these things? Develop patient follow-up, care coordination. You know me, I'm an advocate for care coordination, won't talk about it enough. Build your care coordination process. Disease registries that kind of pull all your COVID patients into one registry so you can track them. We have to definitely monitor. It's a chronic disease now. I think it's hitting a lot of the insurance lists as a chronic disease. because of the long-term effects or latent effects that can happen after the fact. So we have to have a process in place to identify when additional needs are happening. Ones that have passed, we definitely have to make sure we get them set up for grief counseling for those families and support groups. And if there's not support groups, please, by all means, develop your own. Have your healthcare setting talk about what's this look like, what do we need to do to put that in place. So some key considerations. So again, I talked about this. Enforce workload policies. Policies remove obligation, it removes guilt, etc. All that stuff I talked about just a little bit ago. You know, risk plans, and I won't go into great detail here because Kerry is definitely going to talk about community plans and that kind of thing. But your internal risk plans need to include all of these components that we're talking about. And as you incorporate your emergency plan for future pandemics, and the one that just happened, and again, Kerry will talk about these, you need to accommodate for that. Ethics committee involvement, you have to get your ethics committee involved and talk about each case as it happened, because that's how you're going to learn from the decisions that were made. Maybe you're doing swell, you're doing a great job, you've really accommodated from an ethical level, you're hitting all the right boxes, and that's great. But then maybe you need to share that knowledge with other systems that are struggling and let them know this is what we did. Round on your staff. During these, I know we're busy, but you have to take time. Round on your staff, do one-on-one conversations so that you can identify if they're not doing well and if they're struggling. Because the end effect of that anyway is if they have stress and they're getting to a crisis level, you're going to lose them out of your work staff anyway. You want to prevent that. So you have to take those initial steps to keep them healthy mentally. Let them know that someone is listening, be a support resource to them so they know that every day at 10, my supervisor comes around and likes to chit chat with us about how things are going and if we have any concerns. That is a great thing for them to know that someone's always ear open. Encourage staff input and solutions. Don't just tell them. We do a lot of telling. We've done that a lot with all of this. It's time to allow them also to have input, offer solutions of workflows that aren't happening well or what's going on. Enforce break times. Definitely enforce break times and have a getaway space. I'll talk about that in the next slide. Rotate staff through high care areas when possible, like your ICUs, your ED. I know that you have staff that are trained in those areas, but this is a time where cross-training is a must because you'll have people that'll say, oh, I'm going to do this, I'm going to do that, and I'll work all these hours. That's an easy fix, and I know that, but we have to shy away from that, and we have to allow staff to kind of share that burden in those high traffic areas and rotate care staffs through. And please clarify your staff. There's a lot of staff, and they've been on the news talking about this. They are not choosing who lives or dies. You have to make it very clear to your staff, we are triaging. We have a triage process. We are doing that to get our patients through our system and through the treatment process as efficiently and effectively as possible. We do not want our staff thinking that they are choosing who gets to make it or who does not. So a getaway space, like I just mentioned. Sorry, I gotta move this little thing out of my way. I'm not sure why it's bothering me. So think about a nice getaway space, because if it's crazy and you know, New York, Chicago areas, I can't even imagine those ERs and the things, the ICUs that are just flooded. If they have a nice getaway space where they could just go even for 5 minutes, where you remove that stimulus, it's quiet and soothing, just that 5 minutes to kind of de-escalate the trauma that you've just been witnessing so you can kind of feel normal again. It'll just kind of interrupt that stress process that's happening, kind of give them that ability to recharge, stock it with whatever you can, obviously keep it clean, but try to you know, offer water or whatever needs to be in there, soothing music, just enough to kind of de-escalate whatever's been happening for them up to that point. Required counseling, I can't say this enough. You want to require counseling, because this is a way for you to definitely monitor what is going on, and they can't just kind of talk their way out of it. Everyone would be required. Get your counseling figured out, schedule those sessions for everyone around their work life, make it mandatory. That removes any stigmas that may be happening. Everybody's going, we all are required, takes away the obligation because this is an internal policy process that we're following. It can help reduce those feelings of failure. You have a lot of staff that with that suck it up mentality, that if they're required to go, then they don't feel like they failed something. But a lot of times with the required counseling, there's going to be some unrealized issues that are there that definitely can be identified and addressed. Maybe do some peer-to-peer partnering. Somebody that's, like-minded, or maybe you just partner them with a peer to begin with so that you kind of check on each other and kind of a supportive resource when you go in pairs like that to just kind of keep everybody on the up and up and make them discuss their work experiences during these counseling sessions. You have a lot of workers that will just kind of bottle it up, and that definitely has a negative outcome. You just have to have an outlet for them. And if it's the peer-to-peer partnering that allows it to happen, then that's great. And it doesn't just have to be this. You can definitely expand on this. But sometimes we just don't realize how much we may need to identify internal issues. A lot of them think, and I've probably thought it before, oh, I'm fine. Things are great. I'm doing well. But then once you start to kind of dissect down, you see things aren't so great. So to reduce stress on the front end, we need to do better about proactive training to minimize stress, guys. So we want to go through the training. We want to do drills and things like that because, there's a large quantity of stress associated with the unknown. We all know this. If I'm going to go have a procedure that I've never done, even though I'm a nurse, if I don't have enough education on it, I'm worrying. I'm causing my own self-stress. When I had my son, he was premature at 29 weeks, and I had to have a spinal block, and I was concerned. I thought they were going to paralyze me. And I'm a nurse, I should know better. But the risk was there. So there's stress associated with the unknown. But if we take steps to minimize that, we at least have done that much more. We can minimize that stress impact. And the other thought of that is it may never happen. We may educate them to the hilt on all of these items. They may not take place, but I would rather have the knowledge to know, just in case it does. Like with children, we prepare them for very bad things in their lives because we want them to have the tools and the knowledge that if it does happen, I want them to be successful and to have a good outcome. So again, the outcomes are better and the shock is a little bit lighter when they've already kind of been cushioned for what could take place. So definitely educate and be proactive on training for care for the highly infectious patient. Moving forward, we don't know what's around the corner. COVID could just be step one. It may mutate. We may have something new coming. So prepare. Response roles to the ED and then inpatient. Their roles, what is the response? You need to run drills on these. Pretend patients, pretend scenarios, implementing all levels of quarantine. You have to practice this. We talk about it, we have policies, we kind of just adjusted with what was going on with COVID. Some areas had more time to prepare because there weren't surges in your areas, but we have to put on all of the protective equipment and practice that. There's been a lot of cross-contamination for healthcare workers because they were not using the PPE correctly and were cross-contaminating themselves. Identify potential transmission routes during care. Talk about those. Talk about how to avoid them. Enforcing movement restrictions for patients. If you're trying to minimize contamination areas, you really should have a process to restrict patient movements, such as portable items for x-rays and stuff, bringing them to the room instead of moving your patients around. Process to follow during low supplies. What do? We know that this happened. So now we know that it potentially could happen again. Yeah, we definitely want to buy more supplies and have that ready, but we also have to know if we get down on our supplies again, what are our options so that you already have a go-to ready. And understanding that triage process during high volume patients, so that they know that if this does happen, this is who's going to step in and this is the process we're going to follow. Provide that self-help training, dealing with mass fatalities. A lot of workers have a hard time dealing with that, coping with the high stress demands, preparing for the needs of your family, your own family, because you're at work, you're working more, maybe you're quarantined and can't go home. And prepare for, this is a huge one, prepare your workers for the opinions outside of healthcare settings. I still deal with people that think COVID is a hoax and that the whole healthcare system is just trying to make money off of all of this. And that can be very upsetting. But these are the kinds of things that you have to prepare your staff to know that they're never going to quite see things the way we do. That's not everybody. You'll have some that will. But they're going to have to learn how to just kind of cope and deal with the fact that not everyone's going to agree with them or understand where we're coming from. I try to hurry because I think I'm taking too long, Kerry, so don't panic. I'm going to try to talk even faster than I already do. So, transparency and culture. With this, please, share with your staff steps and the facility is taking to clean and why. This isn't just your staff, this is also to your patients. Why the safety of all staff is a priority. Avoid do this because we say so. I talked about that already. Always ask for staff feedback. You have to be careful because we saw this again in the news. Do not create an us versus administration scenarios. We don't want staff feeling that they've kind of been pushed aside, they have no feedback, and they're just basically trapped there giving this care in this horrible situation. You have to create a stigma-free atmosphere, restrict coercion. Staff should never fear negative consequences. Recognize individual contributions and acknowledge those so that staff don't just kind of feel like robots. They have to know that, wow, we really do see the good work that you're doing. Give staff control when applicable. Avoid making them feel unrealistically responsible for the lives of patients. They have to understand we're not going to save everybody, and that's okay because some are just too sick. We don't have to save everyone, and the care that you are not responsible for picking and choosing who lives. And I think working in partners or teams is a fantastic idea so that people always have that kind of go-to partner. Someone to kind of lean on, and that person that's going to check and kind of keep each other, above the line. So for operational goals, really, the whole point here is we want to meet the needs of everyone, not just staff, but patients, everybody that comes into our system. Identify needs internally and externally. Reduce the unnecessary. Provide effective education. Provide those needed services and resources. Excuse me. Improve patient experiences. We have to go back to that patient-centered approach. And sorry, guys, I gotta go. I think this happened. You guys know, it always happens when I talk too much. Retain and improve those community opinions. Have a strong continuum of care and community plan, which Kerry will expand on. And strive for operational excellence, that extra mile. We don't have to suffer our operational performance just because a pandemic or a crisis has entered in front of our healthcare system. We have to have processes in place that will maintain and sustain that operational performance overall. Excuse me. So if we want to make sure from an operational standpoint that we improve for next time, because maybe we didn't do so well this time. So kind of go through these steps. How did your quality measurements change during COVID? Strengths, weaknesses, how did you compare to national benchmarks? Identify areas for opportunities, set targets and goals and push those. Share these goals system-wide. You want everybody involved because you want to build, at the bottom you can see that, continuous process improvement culture. The way you get through pandemics or crises or community tragedies that happen, you have to have a continuous process improvement culture where everybody works together. Adjust to needs, culture of quality, encourage feedback and suggestions. So what did we learn? We definitely learned in the ED setting that emergency departments were overwhelmed quickly. Workflows were disrupted due to confusion. We had constant regulatory changes, conflicting information, and lack of knowledge. Infection control was probably the biggest hurdle that we saw. Supply management and staffing was next, and we need to be prepared for the next time. So from an ED perspective, triage, protection from the unknown. So some ideas to think about, guys, is to have, we had a lot of influx into the EDs, and how do we control that? So a call center triage process, and I've been reading a lot about this. So the calls kind of come through a triage number, and then they're kind of filtered. So it's kind of a call ahead care approach. I know this may not work with anybody because there may be a crisis that they're having a heart attack and they're coming through that way. But if you have a lot of patients that just have a lot of questions, they're presenting, you could use this call triage call center approach Post the number at the door with instructions to call inside, again, unless it's a crisis, and you'd have to be very careful about the wording on that. It allows you to kind of control that influx. Telemedicine screening options from home. If you have the system and the process set up, you really could have patients call in, do a quick screening that way. That helps you kind of filter out that ED misuse that can happen. So it's kind of a side effect. You have a lot of patients that did not need to come to ED, but because they're there, you kind of get that process where you just kind of have to see them. If you could filter them out ahead of time and make an appointment for them at the clinic, it would remove probably 25% of the unnecessary grouping or congregation that's happening out in your waiting room. Kiosk check-ins prior to screening areas. I love these. I've been seeing a lot of these pop up everywhere. It's a simple thing that's put up. It's very patient friendly. I'll talk about those in a second. Admitting process to screen filter every patient. In our EDs, we have to change. We can't just allow everybody to kind of congregate into one big room and kind of check in at the desk and then sit down amongst each other. We have to figure it out differently because, again, things have changed. They're never going to go back to the way they were. We have to separate infectious patients versus medical. We have to have isolation areas for potentially infectious patients as well so that we're keeping them away from each other because and if we want to keep our workflows efficient and protect the patients that don't need to be infected with COVID or whatever's coming, we have to have a process in place. Multiple sites, if you have more than one ED, I've seen a lot of them, they designate one as the pandemic ED where those patients are going there. This is just a resource for you guys real quick. It's a telemedicine hack. It has already started. I won't go through all the information on here, but it's a telemedicine. They have these discussion groups, a lot of hack sessions where people are sharing ideas and things that are going on. So please go back to this and you can go through there, click and sign up. There's no reason, I haven't seen anywhere that you still can't sign up, even though you've missed some, but you might have access to those ones. They might be taping those. Anyway, there's the address and links for you. ED infection control. So why was this a problem for us? We didn't know what we didn't know. We know this. Cross-contamination issues, taking PPE on and off was a huge issue for people. Too many exposed staff. We were kind of just running around for a while there. Containment processes were lacking, especially in our waiting areas. We had exposure confusion. Again, we thought 1 minute it was all airborne, next, and nothing could be on surfaces, and then they changed all of that. And ineffective supply use. We went through a lot of supplies at the beginning, because they said, put everything on, and then we ran out. So we have to look at those and start a new process now and make them your daily norm. It's like preparing for a yearly survey. Just make it part of your daily routine. And as everybody gets used to it, you will work it into your workflow, and then your ED workflow will be better. So let's talk about infection control workflows. So step 1, identify infection sources ahead of time. So we're going to do this moving forward with everything. Infectious patients are a problem, airborne particles are a problem, surfaces, self-contamination, and cross-contamination. So step 2, address each of these sources with a plan. Develop that. I always suggest with the systems that talk to me, get a committee together, have a designated work group, think tank that works on these, and develop those plans. So keep the infection contained. You're going to use your face mask, isolation, social distancing, control your environments, and that movement that is happening. Utilize airflow adjustments. So we have negative pressure rooms, but then there's also filtering options, airflow options that could be altered. Face masks, of course, minimize surfaces, hands-free options. If you can put as many hands-free options in place as possible, that definitely minimizes how much everybody's touching everything. Clean after between every patient, obviously. Alternate rooms while one's being cleaned, have the next room ready so you're not constantly trying to keep up on the clean rooms. Understand proper PPE donning. Get that education out, the clean versus dirty areas. Assign staff to minimize crossover care. Disposable equipment. I know that sounds like, wow, disposable equipment's expensive, but it improves times. It's disposable, and the cross-contamination definitely drops drastically if you just use disposable as much as possible. Or if you have to and you can't afford the disposable, then equip each room separately and do not bring things in and out of other rooms. So step 3, practice drills. Can't say this enough. Practice drills to improve workflow and knowledge. Don't just do these yearly. These should be, in my mind, I think quarterly, if not monthly. Maybe do different subjects each month so it's a constant learning process. Practice putting on the PPE and taking it off. We talk about using it. We have policies in place. Everybody reads stuff, but do we really just stand there and practice putting it on correctly and judging to make sure, did you just cross-contaminate yourself or not? How to maintain clean versus dirty areas, how to control movements for patients, how to do bedside care for infectious patients, all of these items. You need to do these practice drills, how to properly disinfect contaminated areas. Review when to use and not to use particular PPE so that you reduce the wasting that happened with a lot of them. Other considerations, guys, review your policies, procedures developed for pandemics. Your emergency plan risk plans to include pandemics. Your surveyors will be looking for this. Stock supplies for future needs. This kiosk, I'm a strong proponent of these kiosks. I think it's a fabulous idea. I'm running into them all over the place now. Our healthcare generates over 2 billion tons of paper waste yearly. So if you think about it, I'm switching to a kiosk and I no longer have to have all this paper on the walls or handouts, which we shouldn't be doing now anyway. You can put all of that on this kiosk because I've seen them where they run through. They do a lot of education. You can put your policies and compliance things on there, the things that you need the public to know or staff, OSHA, different things that need to be posted. You can use these kiosks because if you save all the money that you would have on the paper waste, it can really, you can cover it for these kiosk programs. There's a lot of, I don't have any resources for you, but I know there's programs that will come in and put them in place and they keep them up to date on there according to what your needs are. And it's really a huge marketing thing as well. The workflows definitely improve when they're utilized. Improve public participation. I'm almost done. Update your public on the steps you are taking as a system to keep them safe. We want our public to support us as healthcare systems. We want them to be actively involved. So we have to build trust. Your safety is our priority. They need to hear this message clear. Some systems are great at this. I've seen a lot of great marketing approaches that have definitely made patients feel safer. Post-infection control and cleaning steps that are happening, post-infection rates. If you're doing well with infection rates and outcomes, let the public know this because they're going to want to come to you. Public service announcements on how to access care. So if you're trying to control workflow or surge flows into your facility, into your RHCs maybe, or into your ED, put this on your public service announcement. ED access numbers and process to follow. Explain your triage processes and what to expect. Continuous updates on your websites and portals. And again, utilize these kiosk systems throughout. Not going to go through these, but these were on our last presentation, but I think it's a great resource to remind you. These are the surface life that COVID can maintain. This kind of goes through, we talked about PPE. These are the N95 masks, which ones to use, when and when not, and how to decontaminate those. And your PPE, education and how to put them on properly and take them off, and how to kind of optimize the use overall. Here's my references. Any questions, guys? Otherwise, I am going to warmly welcome Kerry now. And Kerry, you know I talk too much, so I really apologize. And everybody, if we run over, it's completely my fault, and you can send me a hate mail when we're done here. So Kerry, here's lovely Kerry, and I know that Becky already introduced her, so I won't go through all that.
All right, thank you. Is my screen up where everybody can see it at this point?
Well, let me stop sharing mine.
Okay.
And I think I don't see anything yet, Kerry.
All right, I'm gonna see if I can switch to mine. Then, I love technology. It's my favorite thing to deal with these days. How's that? Go. Everybody see that? Oh, I love the positive voices in the background. Thank you. So I'm going to take what Lesa just went over for your facility specific and say, when we have moments of pause going forward, whatever that might mean, and that means non-surge time periods, because as we know, this isn't going away. We're looking at flu season right on top and behind this, maybe even in front of the next stage of this. Everything's unknown. But if you will look at public health emergency preparedness, go to the internet, pull that up. you'll see there's a whole body of work, studies, forms, everything to help you pull this together. All this is a mix together of public health with your healthcare system in the community. And the key word, and the reason I put this language up there, is it is a chance for you to prevent, respond, and recover from events like we're seeing with COVID or even natural events. So our country has been hit pretty hard, and I think we're so shell-shocked we're not even seeing all of this. But just in the last couple months, that up left picture is from California. Scientists are now concerned that fires are so large they are creating their own weather systems. This is a tornado that formed out of fire. On the lower left is a more recent derecho that went through pretty hard in Iowa, but obviously got us farther east than Indiana to varying degrees. Upper right was a late spring snowstorm in New York. It is known as a lake effect snowstorm in Buffalo. You can still see it's very massive, and even they were concerned about it. And then my part of the world, since I'm in the southeast, we're in the middle of hurricane season and getting ready to run out of names. We've had so many hurricanes already. So it isn't just COVID, it is all of these other factors. And the whole point of emergency preparedness plans is that we are looking at multiple items. That's how we first were asked to set these up years ago by the federal government and by state government, was to have a plan in place to deal. Here are just some of the facts from this year. We've had 48 million people impacted by foodborne illness. We've had tsunamis that have hit multiple states. We've had poisonings. We've had wildfires. We've had chemical exposures. And then my favorite, since I'm in the southeast, so I did a picture. This is from 2005, which I survived. That was a stressful year in Florida. We still talk about it. And it was one where we ran out of names. And the next name for a hurricane after you run through the list is they start with the Greek alphabet. And if you look down over sort of Costa Rica area, or right in here, you'll see that we got to Gamma. We got out to G, and we're headed probably that way again. So the point of all this now is, how do we respond internally, which is what Lesa was talking about, but how can we help each other in our community? And that means we need to have an effective community plan most immediately for COVID, but we need to start looking at post-COVID as we get small reprieves. And you may or may not be in it, because even within a state, we have areas where there are surges and not surges. So in my state of Florida, Miami, Broward County, Palm Coast, all of that area has been in a constant COVID state for multiple months now. In my area in Jacksonville, we had none, and then we had way too much, and then we settled a little bit down, and now we're back in it. We have 4 school systems in Florida shutting down today, most of them in rural counties, actually in the northern part of the state. So as you work around it, there are some areas in Florida that could be in this sort of mini pause, and this is when we need to be reviewing our community plan. And it's time to mobilize people and include people. So things like Lesa brought up as far as support groups, that's going to be not just dependent on your work, it's going to be incumbent on your community to understand what support groups might be needed. And then the other thing that I'm going to talk about here is about half the work being done, and I'm not being mean at this point, but we can have the best laid emergency preparedness plan, and I will almost guarantee the number of tornadoes, hurricanes, a nuclear plant issue in Georgia that I have been through, something has failed in that plan. A good example recently was the hurricane that went up our coast. We had a nursing home that when the power failed, they started their 96-hour generator, and it failed after 4 hours. I don't know of any test for a generator that tests it for 4 or 5 hours to see if it's going to last that long. We usually test it to make sure that it's come on. We have 4 nursing homes in our immediate area where the medical director and key physicians practicing in nursing homes all are COVID positive. What was the backup plan for that? Nobody thought they had to go 2 and 3 and 4 physician deep. So this is a chance to do 2 things. One is public health. That means your entire community, all your healthcare facilities, but also your county, your state, your public health offices, businesses with health components to them. We need to start looking at what the availability of healthcare services was while COVID may have been in your community, or if you haven't had that yet, what you may need based on what you're seeing with everybody else's surges. It is a perfect time if you're in these mini pauses to start reassessing and figure out what resources you need. On the emergency preparedness side, we need to have a response for all events. And we're looking at the pandemic now, but I'm going to echo what Lesa's saying. We've had 13 pandemics since 2000 in the United States. That's not even worldwide. There's more that were worldwide that did not make it into our borders. And actually, with the word pandemic meaning worldwide, the one that really hit Asia and Africa extraordinarily hard was Ebola several years ago, and we had, I think, 4 to 6 deaths in this country from it. So it is something where we have to be ready to mitigate, be able to respond, and be able to recover. And so that's the work that we have to do right now. I have included a blank of this. I just created this for some of my own facilities that are reviewing their emergency preparedness plans right now because we're so centered on COVID. There are other things going on. Just saw the 4 pictures that I posted. Every part of our country has been hit hard. And if you want to throw in the other one I didn't have on there because it's this week's news is the Southwest being hit with the heat of the century. I think Death Valley, where very few people live in Death Valley, but outside the national park, inside the national park, it hit 130 degrees yesterday. So we have all sorts of things. This is sort of the list that we typically start with. Each of your areas may have bits and pieces of this or additional things. But we're working just even in the last 2 years. If somebody has the time, it is helpful to go back even a few more years. We are definitely in a 100-year cycle with this pandemic. The one that we are referring to the most is going back to the Spanish flu in the late 1918 through 1921 generally. And what I'm hearing, we're going back to the Black Plague, which is mid-century of our history. We need to know that these are rare and in between, hopefully stay rare, by the way, but we have these other things. So there is a blank form there if you want to do this as an exercise as you prepare for the things specific to your area. So emergency preparedness means that we have not only your facility with protocols, not only your facility with policies, we've got facilities and entities around us that have their own protocols, have their own policies. Your nursing homes, your home health agencies, your hospice, your if you have a rural health clinic, if you have even larger physician groupings. So we've got to stop and make sure we're all on the same song sheet there and who's helping who and who has resources that maybe the hospital doesn't have or maybe the nursing home doesn't have, and can we share these? Part of it is looking at your transfer agreements. When the nursing home shut down admissions, one of the things that hit hard was hospitals looking for placements for post-acute patients that still needed to be head in the bed, and that's where the swing bed programs really have taken off, but there's not even enough beds there. But there's still transfer agreements. If in a tornado or a hurricane or a fire, your building is damaged, we have transfer agreements with other hospitals. Your swing bed program should have a transfer agreement with another skilled facility and or swing bed program somewhere else. In Florida last year, we got really scared with our transfer agreements because we were in the 3rd year in a row where a hurricane covered the entire state of Florida at one time. Transfer agreements mean normally we move people off the coastline from hospitals and nursing homes into the center part of the state, or in my area into southeast or southwest Georgia, and even a little bit into South Carolina. When you have the entire state covered and that storm is projected to go into Mississippi, Alabama, Georgia, or on this coast, Georgia, South Carolina, North Carolina, where do we transfer them to? And in our area, we stopped and looked, and the closest transfer agreement we could have was Tennessee. Now, how would you like to take 12 nursing homes, let's just make 100 beds each, even though some of them are larger, and try to move that many people to Tennessee to other nursing homes? It isn't going to happen. So it is time to check with transfer agreements and what are we going to do when buildings are damaged or other things occur. This is also a huge piece of preparedness that we have, I don't think, done very well. is looking at mental illness psych patients, and I will add drug and alcohol as a separate category under this. We all have a mental illness diagnosis at this point. I mean, every one of us. We've got some degree of depression. We've got some degree of anxiety. Most of us are tired. It's impacting our mood. We may not be to the point of chronic. We may not be to the point of psychosis. Your kids, I'm talking to teachers and friends that are in counseling in schools, and they're just stunned by what they're seeing as kids start back to school. None of it planned, none of it caused because of a home situation necessarily, but because of the blanket of concern around the world and certainly in this country. So we've got to be able to do a couple things with that. What are the groups in your community? Sometimes it is support groups. Sometimes it's churches are reaching out and helping that area. You may have a mental health coalition that we need to be getting information out on, but something needs to occur where we are trying to deal with the worsening anxiety and depression in particular, but other things that are going on. And that means we also have to have an ability to separate COVID from non-COVID. And I seriously doubt that was in any of our policies or in any of our plans before January 2020. So what are the assessments that you have in place for mental health concerns that are community-wide? That's the discussion that needs to be occurring for your community. All right, telehealth is going to be a huge boon. Lesa brought it up as one way to kind of funnel patients correctly through your system. I know we have telehealth follow-up from surgeries by physicians now. We certainly have telehealth with primary care. This is a list of the current, as of 3 days ago, of what is allowed via telehealth by CMS. Again, I'm not going to read this at this point, but that's the most recent list, and there may be some things on there that you haven't taken advantage of. More importantly, we've been sort of on the run. Also, we didn't have telehealth, we didn't have it, we weren't allowed to do this, we weren't allowed to do this, and then boom, all of a sudden in May and June when we started getting the waivers, yep, you can use telehealth. So there are some things you need to double check, communication with insurers about what they're allowing individually with telehealth, because that CMS list is a Medicare covered list. Medicaid in each state will be a little different also. There is use of teletriage, but there are different expectations in different states, again, state rules and federal rules, but you might want to look into that. I put in here a reminder. I don't think we should, but I've seen 3 stories on it so far from different parts of the country where employees trying to get information out use Facebook or Twitter or other things. And as you know, we're not supposed to do anything where information can get out from the hospital. So just as a reminder, and then you need to also, when you're looking at telehealth, the regulations are different state to state. And while many states are allowing interstate licensure rules now for physicians and others, that may not be your state. So please make sure you're heads up on that. And then I think we got an education piece that the hospital can take on, which is how are we going to get out into our community and let people know what is a virtual visit, what can they expect, maybe what notes should they be writing down so that they're prepared to talk to a doctor via telephone, if not Zoom, particularly if they're of an age group that has not used Zoom or other platforms recently in their lives. I've put in here a swing bed example. You can take it for any setting, any outpatient process you have, any rural health clinic you might have, but you've got to start looking at your admissions criteria. And I put there advanced directives because it's very important with swing, and I think it's becoming more important in all of our settings because of the what COVID is doing to our country with deaths of patients of all ages. But you've got to look at your admissions criteria. COVID wasn't on there prior to a couple of months ago. Is it on there now? And what kinds of patients are you accepting or not accepting? Again, your transfer agreements, you need to contact all the sites. If you have COVID patients, they may not be accepting them. If you have non-COVID, they may be all COVID. You need to make sure there's an updated list. Lesa mentioned survey several times. Staff competencies are coming up like mad. They should be ongoing staff competencies now, particularly around the equipment and supplies. I know the nursing homes are getting busted pretty routinely for CNAs not taking gloves off the right way. They were all trained at one point, but if it was 12 months ago and now they're trying to go room to room, it doesn't take much, you know, to use a gloved hand to take a glove off the other one by touching your wrist and other things. So that's updating and constantly going through basic competencies now. You need to have a list and know what if the nursing homes are taking admissions, because that's where your swing bed is probably, in this case, in this example, going to get more requests for beds. I'm working with a facility in North Carolina now that has started the emergency swing bed program that is allowed under the waivers, and it's been a bear to get going, but they're filled. That's how many beds are not available in the state of North Carolina at this point. You may have a curtailed admissions process. We usually go through in swing beds, we check with the insurance, we do this, we make sure our doctors know, we've talked to therapy, we've talked to pharmacy, et cetera, et cetera. That takes time. What have you done to try and shorten that list or get your team on all one call or one process? But we can't take the time when a hospital's calling a larger hospital, referring hospital, they need somebody to take that patient immediately. And then are the waiver overflows being used when we're in the bolus of COVID patients, and what's the documentation to back that up? Appropriate staff and backup. Most nursing homes are significantly down on staff. I have one client right now that's down 14 CNAs in a nursing home. And that's the lifeblood of staffing in nursing homes. And there is no agency involved in there. They can't get students out quick enough. And even with students, they've got to have somebody supervising them. So we're in a jam. And then I have more than one building where the medical director has been out with COVID, whether it's a nursing home or whether it's a rural hospital. And in several of the nursing homes, all the physicians were in one group and treating in the nursing home, and they all are COVID positive. Who backs up that list now? So this isn't just a backup. This is a backup plan to the backup. We're getting delays in medicines. We're getting delay in food. We need, as you know, in emergency preparedness, always to have the answer about water supplies. That involves city and or county people helping you. So it's a time to review all of this, in this case, for whatever setting you're in. And then I'm going to go back to what Lesa said, which is the mental health is impacting all of us, whether we're working, whether we're sick, whether we're not sick, whether we have family members sick, whether we have neighbors that are sick, or how about even neighbors that are quarantined, you know, people trying to help them grocery shop and so forth. We've got a long path ahead of us here. And so these disruptions are for, in your case, outpatients and inpatients. Again, telehealth, anything that we can do to have contact with patients appropriately would be great right now. We are seeing more PTSD, as you can imagine. We have more drug and alcohol issues right now. But this impacts even the chronic, the bipolar, the schizophrenic, and other disease processes that may have been under control, but they can't see a therapist. They're not taking their meds appropriately. Whatever the issue might be, we've got some homework here. So one is, as we need to shelter in some of our emergencies, what are we doing with those shelters for COVID and non-COVID? But also, what are we doing in shelter access for those that have mental or behavioral health issues? What is the access to therapists, counselors in your community? Do we need to expand that list? Again, using telehealth and explaining that to this patient population will be very, very important. Most of these patients have built up a relationship with one place or one therapist/counselor, and to go to a telephone, not be able to see people will be confusing and may throw them off. Medications, making sure your hospital has a supply for what's going on in your community, including methadone, which is not something we typically think about unless we are a drug and alcohol facility. And then ED planning will be huge. And Lesa went through that entire list of all the people that are going to be hitting EDs and how are we going to handle that. So I've set up a checklist here, checking with other facilities, allocating the staff, who's going to be doing the mental health assessments in each of our settings now, and then what's our contact list for responders for specific issues. And that may need to be updated or it may need to be expanded depending on what's going on in your area. Community planning, there's a couple of things that are post-COVID but immediate. And I say immediate is when you're in a pause, we need to be doing this before flu season. You need to look at your facility first on the decisions, whether we took COVID patients, for instance, into swing beds sort of accidentally. Do we want to do that going forward? What does our policy say? What's the backup for all the things you just went over? But the second part of the community planning was what needs were met or not met in the community, and who are our designated partners? What were we doing about transportation? What do we know about shortages in other healthcare facilities in the area, in the sense of the community responding to whatever's coming? And did we have any partners that had issues with delivery, staffing, supplies, those sorts of things? We need to know that and see if we can work that out. And then there is the restoration actually of buildings, flooding. We have a great part of the Northeast that was underwater for a long time. Now the coast of Virginia, North Carolina, up into the DC area had floods with the last hurricane. That shuts down buildings, and that shuts down access to health services, maybe other than the hospital, maybe including the hospital in the other areas. So the last one is, what was the pre-existing relationship that you thought you had in place, but it didn't work when we were so far away from normal? What do we do to fix that? It is a time to figure out who, meaning your entity, who do you want to be going forward? Do you want to have a swing bed program? Do you want it to be all COVID? Do you want it to all be non-COVID? How are we going to split our ED to COVID versus or infectious diseases, I should say, and non-infectious diseases? We've got a planning period here that we need to do. And the preparedness part of it is what didn't work. And a lot of it will come down to communication, both internal and external. I saw a couple examples already in the last couple months of EMS and hospital differing on who needed to be transferred first and who was going to pick up which patient. Those things need to be settled when we're in a slight pause, or at least not in a surge situation. And then looking at how we're going to deal with all the items that came up. I've listed a couple to hopefully prompt you to think through things, but basically the two big ones are going to be storm fatigue and compassion fatigue. Compassion fatigue is the ability of each of your staff members to keep giving and giving and giving and giving, and we keep rolling through more people and more people. So connecting the dots in your community, using telehealth now, if you can get that set up, not just for you, but for other entities. Do we have the FQHCs or HCs in your area that could be distant telehealth sites? What are we doing connecting the community to public health and clinic and physician offices instead of using your ED? And you need to know what your barriers are. You need to know what they are now. We're going to probably have another role if we ever get out of this first roll of COVID. We certainly are in natural disasters across the country. We know we have flu season coming along. Whatever we plan for in 2019 is not going to work in 2020. And this is your chance to sit down, have everybody write down suggestions, and let's start working through the specifics. So when you hit a pause, what is the behavioral support that you had? What was missing? What was needed? What's going on with your skilled nursing facilities? Are they taking admissions or not? Or when might they take admissions? Have we done anything, for instance, on the expedited credentialing as we needed additional staff, physicians, and so forth? What is the scope of need for PPE, pharmacy, medical supplies? Was there enough transport needed? So all of this is something that you can be doing step by step or on one great lump of things as you get time. But we need to be doing it before we come into the fall and potentially have the flu and COVID hitting us at the same time, with the flu this year being an unknown entity. I remember in December looking at the statistics, and they thought this flu season would be in between the prior 2 years. So 2 years back before this year, we had a really bad flu that killed about 61,000 Americans. And then last year we had a, quote, lighter flu season, and they expected this year to be in between those two. Well, in between now means flu and COVID at the same time. So I think those numbers are going to be blown out. And then the other thing was the cost of this. When we initially looked at emergency preparedness plan, it was expected that it would cost hospitals about $8,000 a year. It's more than that now. if you take in the fact that I have the second bullet point there, that 69% of our hospitals last year diverted patients to other hospitals because of nursing shortages, which were there before COVID, and certainly staff is there now. So you need to use these starting points and start looking at what are you going to do for the next 18 to 24 months. And that means an awful lot of planning for things that we don't know how it's going to impact us. And then post this, I have listed some resources, and there's a whole list again of the telehealth resources in addition to others. And I will stop with that and see if we have any questions.
I haven't received any questions, but the slides really provide a great outline for people to be able to reference and follow. So since we are a little bit over on time, definitely if you have questions or you're working on your plan and you would like input, reach out to me and I will connect with Lesa and Kerry and we will get your questions answered. But a big thank you to Lesa and Kerry both for really providing some comprehensive information today. Much appreciated. Thank you so much, everyone.